Heather, are you there? You're muted.
Sorry, yeah, sorry. I'm still getting used to still getting used to this from Teams. I apologize.
It's okay.
Are you able to see the screen okay?
Yes, thank
Okay,
you.
wonderful. So just wanted to introduce myself. My name is Heather Campbell. I'm the nurse manager in the virtual ICU of Northwell Health, and I'm joined by Craig Hertz, Dr. Craig Hertz.
I am Craig Hertz, Medical Director, Telehealth here, or Virtual ICU here in Northwell.
So those of you who may not be familiar with Northwell, we're one of the largest healthcare systems in New York State. We have over 21 different hospitals, 900 care centers. Our service area is about 12 million people, pretty large, 85,000 employees. We treat about 2 million patients annually. I don't think we have our reach all the way up north yet, but I think we're still in the downstate region. Just wanted to tell you a little bit about our virtual ICU before we get started. So um, we cover about 509 patient beds. We have about 100 virtual ICU team members. This consists of 41 intensivists and critical care, ACPs. We have about 40 ICU nurses and 8 administrative support coordinators who help us throughout the day. We're one of only 2 virtual ICUs in the country to have the AACN's Beacon Award. We were earned silver in 2023. And we work very hard to make sure everyone's certified. So we have about an 80% certification rate on our CCRN for our nursing staff. So Craig's gonna start. I guess he'll just tell us a little bit about the program, how we started with our good catches and how they developed into our safety round program.
Yeah, so thanks. So as we all kind of do other things, which typically happens on virtual meetings, I will pull what I believe is a quote from Jeff Bezos, who essentially said that when the data and the anecdotes don't match, right? And I pick him because there may be people finding good deals on Amazon. When the data and the anecdotes don't match, believe the anecdotes. And so what we are finding is as the programs that were kind of being developed uh, with the various sites we cover and in partnership, wanted to understand where is their value, right? And in my mind, kind of the people we serve, the patients, the teams, the communities, they're the ones that are going to describe and define their value and what is important to them. Certain metrics that were historically captured, length of stay, ventilator days, mortality, never really painted the picture that they maybe did 2 decades ago, maybe even a decade ago. So we started what we called a good catch program. It has since changed names because some of the feedback was that these aren't really good catches, these are more partnerships. So we changed the name. Either way, what it was a bidirectional narrative around what that experience of the interaction was like. So for example, if one of our nurses received a notification that a patient was hypotensive and they camered into the room, what did they see? What was that experience like? Maybe the patient was hypotensive, but maybe there was something else going on. If we were asked to put in, say, a chest x-ray, maybe there was something else we saw. There was actually a very unfortunate case where we saw blood on the floor and the patient was having a GI bleed. So those are important stories to understand. We started capturing those. I say bidirectional because our bedside partners, patients, families, nurses, whomever, also have the ability to give us, what did they see? What was their experience like? With those, what we started finding was that the reason for the call, the reason for the interaction may not always be the reason or the most concerning thing, right? So patient concerns are not always their biggest concern. If we saw somebody that was tachycardic, what was the reason behind it? Maybe they were getting out of bed. Maybe their sedation had worn off. Maybe they actually weren't tachycardic. Maybe there was something totally different going on. So from that, with our quality advisor and Heather and some of the other leadership, we started kind of doing listening and learning times. A lot of our nurses go to the collaborative care councils at our various hospitals that we partner with, and learning what are their needs, what are they really most concerned about. And so from that, we evolved into safety rounds, which Heather's going to kind of talk a little bit more granular about. What is that process? What did that look like? How did we create them?
Thank you, Craig. So as Craig mentioned, we started off with the good catches. We kind of saw we took all the data, and while we were sifting through it, we saw some trends, particularly with different sites and different units. They all have distinct personalities, as we all know, and there were certain things that the nursing staff and the provider staff used more than others, things they were engaged in, other programs that they didn't have a need for. So we were able to look at our good catches and help tailor the engagement to each site, while at the same time identifying the needs of what specifically they were looking for, what quality metrics they were falling out on, and what we could help force multiply and help increase. So the safety rounds program ended up being, I think I have it on my next page. Yeah, so the safety round program ended up being a kind of a mechanism through which we were able to do hourly rounding on these patients. We had audio-visual equipment that was hardwired into each patient's room. We made sure that the leadership at the site was the one who was identifying the patients who would be eligible for the program. Depending on the size of the unit, it can be anywhere from 3 to 4 patients within each site. The charge nurse usually determines the number of patients that will be eligible for this program. When we first started, they tried putting every bed on, of course, but we just because of our time constraints, we could only do 4 patients a unit. These patients were hourly rounded on. Things that we were looking for specifically, we were looking at their vent setup to make sure everything was connected, nothing was alarming. We were looking at the drips that were running. We're looking to make sure that the patient is comfortably sedated, or if they're not, that they're pain-free and that they seem to be A&O ×4, and if not, they have safety mechanisms in place. What we found is that our good catches, when narrowed down into these specific patients who were at risk for high safety events such as falls, self-extubations, confusion and delirium due to CWA or sundowning. These patients were where we found our good catches. They were where we were able to enforce safety rounds and were able to really save the bedside some time by monitoring them, as well as providing that support and relief from them so that they could, do something as simple as take a bathroom break, go grab some water, look at their phone for a second, so they found it very helpful. Even though we came from the Good Catch program, we ended up circling back because all of our safety rounds yielded even better good catches. And we were able to take this, and in a partnership of collaboration, we reached out to the bedside nurse managers, to the providers, and we kind of turned it into a celebration of collaboration rather than punitive or any kind of big brother type of thing, which I know can happen sometimes with the image of the virtual ICU. So these collaborations really uplifted and recognized our partners at the bedside. They in turn would recognize us, and we were able to do this through monetary things such as recognition points, which you can, in Northwell, you can use them for gift cards and things like that. We were able to do it through verbal recognition to their peers so that their peers got to hear their good catch. And then we also got to do it through acknowledgement from leadership. So having leadership, recognize you and being able to, hold your head up high and smile that day, little things like that. We even, just as an aside, we even, on a bedside nurse's suggestion, we even themed it as a baseball theme because it was good catch. So we have like a baseball theme, and we do this every couple months. Our quality data advisor is amazing. She goes through, she screens them along. I know Dr. Hertz looks at them very regularly as well. And we're able to kind of highlight these professional collaborations that come from this project. Just also wanted to show back in 2023 at the Search Conference, I'm not sure if anyone attended, but it was the National Telehealth Research Symposium. A few of our leaders here put together this poster presentation highlighting the Good Catch and Safety Round program and how it was utilized in the virtual ICU to promote patient safety. You can see some of the Down here, what looks like an iPad display or an iPhone display, you can see the collaboration data sheets that we used in order to get some of that quantitative and qualitative data. We were able to show an increase in in better patient outcomes, and we kind of go through all of our things here. And then just to give you our update, this is last year's data. Just sharing that, we were able to improve or stabilize about 99% of the interventions that we had. And then we had about 6,766 patient encounters for safety rounds in the year 2023. And so we've received, in addition to the quantitative data for the context for the story, we were able to get some really wonderful stories from the nurses that they really appreciated it. One I always like to share is when the nurse manager at the bedside went around with the survey, we give them a QR code and was just asking, do you have anything you want to share about safety rounds? I guess the nurses that were talking to the manager thought that it was like being threatened to be taken away, and they were like, no, you can't take that from us. Like we love this. Please keep it. And the nurse manager reassured them that no, this is just to get your feedback. But that in itself was feedback for us, knowing that we've become not just an adjunct tool for them to use, but we've completely integrated into their workflows. And that was kind of the overall goal of it, to become a true partner to the bedside. So yeah, so we were very, very happy with it. Does anyone have any questions, or do you guys have any similar programs at your sites?
General costs.
General costs. Thanks, Bob.
Bob, when you say general costs, tell me about that.
So generally, what would it cost to implement a program like this at a location that doesn't currently have it? What's required in terms of infrastructure? What's required in terms of equipment at the location?
Yeah.
Those types of things, generally, before you can even start.
And I think that's fair. And so if nobody had questions, I was going to kind of dive in along this line, like what were barriers and what were things that were easier and harder than we would have expected. So costs of these programs, they vary, and in New York specifically, about 60% of the cost is usually a labor cost, whatever that may mean from a virtual component. Infrastructure used to be a pretty heavy lift. I think with kind of more edge-based computing and edge-based devices, where really the processing power is in the camera or in the audio video conduit, whatever that may be, those prices have gone down. For example, a fully hardwired room in an intensive care unit that is integrated with vitals and labs and everything like that can sometimes go upwards of $100,000. Lighter versions of that, maybe half that cost. I think part of this is once that initial layout is done, right? Once that cost is spent, it's done. It is a sunk cost, and that's it. Licensing fees and things like that tend to be more subscription models, so kind of like your Netflix. I don't know if that answers it. Where else should I go with that?
No, that's all I was looking for, and I appreciate the feedback. Thank you.
Mm-hmm. What else?
Feel free to unmute yourselves or put your question directly into the chat if you have any questions. And if you're both able to share your contact information too, we'll be sending out the recording. And so if anyone has any questions at that point, they could also reach out to you directly.
Sure.
Thank you.
You're welcome. I will offer up a couple, which is that I think, virtual health, however that is defined and wherever that is defined, is a tool. It is not a panacea of solutions or the saving grace for all things in healthcare that may or may not be working. And Heather brought up a point that I personally missed quite a bit and realized it was something that was well overlooked when we started in kind of pivoting our program in the sense of partnering closer with the bedside teams. And I think part of that was really understanding what did they want to get out of it, and what was meaningful to the people that were going to utilize this program, and not necessarily. I mean, I think we're all in this to help people get better, to help humans in their time of need. But what's something that Heather talked about was and Northwell calls them my recognition, but some sort of recognition of the interaction. What I have found and what I have heard stories of is that recognition, and I think most of us want to be recognized for the work that we're putting in and the effort we're putting in the day-to-day of taking care of other humans. And that recognition really started to solidify how important this program is to people, how important this program is to units, intensive care units, emergency departments. I even think as you go into the outpatient world, into the ambulatory space, really finding a way to celebrate the small wins. I mean, all of us are excited when there's a big win, but it's the small, and I'll even say mundane wins every day that allow us to be better. And that process that Heather put in, and really with the nursing, all of that has solidified this program to where now it really is kind of a beautiful thing to see. And every day we get 4 or 5 different interactions, and probably even more, where we have found something that may seem mundane but really is meaningful to the people on both sides.
Thank you, Craig. Do we have any other questions? Heather, Craig, do you have additional slides?
These were our main talking points. We wanted to have more of a discussion based, because I know each audience has a different thing that they're looking for, a different outcome that they're looking for. So some audiences like to talk about overcoming barriers of engagement, including when nurses are resistant to use the technology at first, things like that. So if there's anything that any aspect of implementation for a virtual ICU hourly rounding program that you're interested in, be more than happy to discuss it with you.
How do you get around hesitancy for, with regard to staff, but also to patients? I'm sure you run into that as well. Could you talk a little bit about that?
Sure, no problem. So in regards to the staff actually using our program, we found that frequent in-person site visits are very helpful. As mentioned, we geographically see patients all the way out to the eastern end tip of Long Island, all the way up into northern Westchester County and around there. But we make it a point every quarter to go to all the hospitals and see everyone. We found that the most crucial part of winning over the staff was the leadership involvement. If the leadership was excited at the site, we knew that even after we left, they would keep the momentum going while we came back and touched in and on our end. The other thing that we found instrumental is because we're not physically there, they don't see us every day, it's easy to forget that we are a resource. So in order to build the habit, so to speak, of using us, what we did was our charge nurse calls every unit, every ED, and every step down that we support every morning, about an hour after their change of shift, in order to kind of a friendly reminder that we're here and what patients would you like to be put on safety rounds. And that way we have engagement every day. Even if it's a busy morning and they may forget about us, by calling them, we're putting ourselves back into the role and oh, okay, yeah, you know what? This would be a great patient for you to put on and whatnot. In terms of change implementation, I know we've all probably studied it very much, but there are always going to be those that are resistant. One of the mitigating factors with that is utilizing the excitement of novice nurses. They are new to the program, they're new to everything. So they may not have already developed their standard of practice that they are going to be implementing prior to us coming on board. So what we do is we have a system where those that are regionally close to us actually come to our core, come to our unit. They spend about 4 to 6 hours with us, and it really helps make us into, makes us more personable, makes us an actual person instead of a random face on the camera. The other thing that we do is we work very closely with novice nurses once they finish their critical care nursing fellowships at their site. So normally they have a 6-month orientation that consists of, didactics and skills labs and things of that nature. And then when that finishes, we take over and we do a 1-month support formalized education program with them where they call in. I'm not sure if I mentioned earlier, all of our nurses have 5 years ICU bedside experience minimum, most have decades. And so we're able to match each novice nurse with somebody who would be a senior nurse on their unit. And as I know, we're probably all experiencing retention nationwide is an issue. The virtual ICU is a way to retain within your healthcare system seasoned experienced nurses who may not be able to work at the bedside anymore as well. So we match them with novice nurses who are very excited, and we put that together, and we're able to create fans. We're able to create people who want to participate, who are engaged in our program and want to know what we have to offer. What we found is when we create those fans, when we come back in 3 months, the people who didn't want to know us now are like, okay, I saw that you did X, Y, and Z documentation for this new nurse. I want to get in on that. So that's kind of how that works. By creating the fans, you kind of show what's possible with your program. And that has kind of really fueled our engagement. Recently, we actually partnered with Lenox Hill Hospital in New York City, who maybe like 4 or 5 years ago, was not a unit that really engaged us much. They were a unit that, we thought they were under the impression, they wanted to work. It was working for them. They didn't think they needed us. We worked very hard using things like the good catches, using recognition, using site visits and safety rounds. And we created fans and we created partners and we created people who wanted to collaborate with us. And now they're one of our most engaged hospitals, most engaged units. And we actually quantified and graphed our relationship over, because we had done a survey a couple of years ago to get their perspective of us. And then we did a survey 3 years later to see what they think of us now. And we're able to match those with the metrics of engagement, usage, and other quality indicators. And we're actually able to graph that, post it, and we actually went to Denver this, I guess, spring and presented at the AACN's National Critical Care Nursing Conference. And it was really wonderful to kind of show that engagement, show how to create excitement for tele-ICU programs across the country.
Thank you. And we have a question in the chat. Maxine is asking, can you speak a little more about the program/technology?
Maxine, will you expand upon that just a little bit? All right. I'll start, and if I go down a rabbit hole that is down the wrong path, please bring me back, Maxine. So technology, for us right now, our contracts sit with usually Philips and Teladoc. We being Northwell leverage all of our internal prescribers and providers of care. I think we're all providers of care and treatment. So nurses, physicians, NPs, PAs, RTs, whatever that may be. Northwell employs and deploys their own. So we don't use outside vendors. The technology component, really it's anything that is HIPAA secure and PHI secure and compliant, two-way audio video. From an ICU standpoint, at the moment, we use hardwired beds in certain ICUs. We also have cart deployments. The technology is going to shift. I think handheld devices are really nice, though it does require someone with a steady hand to hold the device, which doesn't always happen, especially in a resource limited place where you actually probably don't have a free hand. So sometimes having a hardwired or a stationary cart or some sort of secured, whether it's a pole on a cart, something like that, device is helpful. Let me stop there. Is that going on the right path, Maxine?
Yes, I just wanted to get a better understanding of, from a virtual position, from a virtual standpoint, how are you connected? How is the nurse connected to the patient versus the bedside nurse? And therefore, what is that nurse seeing that the bedside nurse is not seeing? I'm not sure if I'm understanding you correctly, but
Yeah, all right. So right here, right? Like I don't know if you have me on camera, but I'm on camera. You can just see here, right? You can see this space.
Yes.
All of the cameras that I'll say commercially available, but I do really believe that if you're going to deploy a service like this, wherever that may be, you need some sort of camera that has a little bit of pan tilt zoom. There are cameras that have, and I'm going to say air quotes, AI, where it can pan, tilt, and zoom to the right place. I don't know if they really live up to what they sell. They're typically wall mounted or ceiling mounted. Even the carts are usually 5 to 6 feet from the ground. So you get a little bit of kind of a zoomed out bird's eye view.
Okay.
What the bedside team will see, patient, caregiver, nurse, whomever, is this interaction right here. Usually what's going to be displayed on a screen for most vendors is going to be whoever's on camera, their name or some, whether it's first initial, last name, last initial, you can customize that, and some sort of credential. Most vendors have ways to bring in multi-parties. So one of the things on here that also ties into this program, but other programs, are the ability to bring in family members.
Oh, okay.
What we have found, and I won't speak for our telepsychiatry, but with telepsych, especially in adolescent or pediatric cases, sometimes it's helpful for collateral if they're allowed. Critical care perspective, or even emergency department perspective, it's very powerful. We're all familiar with what those scenarios are like. They're not really the best scenario. And when family can't get there, or a caregiver can't get there, or a loved one can't get there, sometimes being able to virtualize them in is very powerful. They can be in that moment. They can guide the story and kind of the journey of how the patient ended up in the ED or in the ICU. And you're not delaying a decision. You're also able to communicate and have that conversation when the patient and caregiver is ready to have it, as opposed to saying, "Oh, be here at 3:00 Monday. Yes, take off work, take a 4-hour drive to here." You add that flexibility into a really kind of unfortunate time of life.
Thank you.
You're welcome.
I just wanted to go off. Craig made some really great points. I think one of the number one things that I know our bedside partners appreciate is being able to see the name of the nurse or physician or ACP, as well as the credential. We do have situations where we're giving bedside support. It could be a code or an RRT situation where maybe the virtual ICU nurse is acting as a scribe, and the ICU ACP or physician is acting as a consult or perhaps running the code. So it's very helpful for them to see the two faces with the separate titles, so that they know who is, maybe running the code and who is just recording. So it's a very helpful display. The other thing Craig mentioned, which is one of my personal favorites, is our Family Connect program. It was born out of COVID when we did have, I know all hospitals had to come up with unique and creative ways in order to leverage the technology that we had existing in our units in order to bring in family members who were, strictly barred from the bedside. And we found it to be a huge patient satisfier. A lot of units who did not have the hardware installed were using things like like iPads and phones and things of that nature. One of the benefits of our technology was that we were able to do a nice tight zoom of the patient's face, not to show them, the CVV and the vent and all the drips and whatnot, and then to also have multiple family members on at once. So if you have a family member with a large extended family, you can have 19, 20 people on that one call who are all able to see the family member, with the benefit being that, and this is a part of the technology that I really admire, is that you can take the virtual nurse is still in charge of the camera. So even though they pull out to give privacy to the family, they're still the ones in control of the camera. So you're not going to have family members, because the bedside was like, I don't want the family members zooming in on this and zooming in on that. So we still hold the control of the camera, but the family members can all attend. And people out of the country, I think we've connected Poland and Spain, and as long as they have an email address, we can get them into the room. And it's, as Craig mentioned, very important in those end-of-life situations where we can bring family together in their last moments. It's a great way to leverage the technology.
This is Andrea. Can I ask, how does consent work in those circumstances? Are you just taking like verbal consent from the patient at that point, or are you documenting consent anywhere? Can you talk about that?
Yeah,
Yeah,
sorry, Craig.
no, please go ahead.
Oh, I just, the general consent that they sign upon admission covers the virtual ICU. At any time, they have the ability to, sorry, no problem, sorry. They have the ability to opt out. So our cameras have, what would you call them? Kind of like icons with a cross on them to X them out, just to let people know that if you have maybe a patient who is actively dying or a patient who just doesn't want to participate in the program, they will have a symbol, an icon on their camera that will let people know not to camera in. I have to say, I've been here 5 years, and other than people who are on comfort measures, I can hardly think of anyone that didn't want to participate in the program. Most found it very helpful. Consent, when we introduced the program, so we have a KPI for our own internal staff, which is that every nurse has to camera in within 30 minutes of a patient being admitted to the ICU. So when we camera in, we have like a spiel that we say basically that introduces ourselves, lets them know where we are physically, because they often want to know where we are. Like, are you outside my room? Are you, so we tell them where we are geographically. We let them know that the patient doesn't, the camera does not record. That is something that I think puts their minds at ease a lot. And also that with the technology we have, our camera, when it is off, it turns around and faces the wall, and it's right up against the wall. So there's no perception that it's looking at something when it shouldn't. I think that gives peace of mind to the bedside as well. When it does turn on, our faces will come up on the screen with our titles. So you'll always know if somebody's on camera. We also have a doorbell chime that our software has, where we always, when we're educating our nursing staff, we always like to, and our ACP and physicians, we always like to say it's when you come into a patient's room, even if it's through visual audio technology, it's the same way as if you were opening a patient's door. So always want to, instead of knocking on the door, you can ring that doorbell just to let them know that you're entering the room and you're going to be doing something, checking something out, or doing something like that.
Thank you. I think that's all very helpful information, because when it comes to virtual care, we often hear privacy is such a concern for patients.
Sure.
And so having those steps in place to just make people more comfortable with the process, I think can make a big difference. Do we have any other questions from participants?
Andrea, if I can borrow, just tie into what Heather said real quick.
Sure.
That I want to, I don't know, I looked at participants, and there may be counsel on here from one of the organizations, and I just want to make sure that I clarify a couple things. One is, in the acute care space, once there is consent for treatment, virtual, whatever that program is considered under that same consent for treatment. So it's actually embedded in there. So this is not looking at an ambulatory space where you need that consent to make that connection, that people will, you have to have that in some sort of writing or verbal. So I just want to clarify those 2 points. The other part that you just brought up, which is privacy, one of the things that we do internally is really go over a lot of kind of unfortunate lessons learned in the sense of privacy, and making sure that, when we camera in a room, we just don't start speaking. There have been times I have been at fault of this where I will camera in and start talking about something clinically without looking around the room. And so I think it is important that as you deploy programs like this, and one of the things that when Heather talks about doing site visits and kind of the handshakes and hugs, it's very important to lay that foundation that no one's there to spy. When we come into a room, we'll go around the room and we'll ask, hi, who are you? What's your relationship? To make sure that we're not about to say something that shouldn't be said or interact in a way that that may be offsetting or off-putting. So I just wanted to lay that in there. Sorry.
Yeah, that's a very important point. We do a lot of work with our Live On New York partners for organ donation, and we are very cognizant of the fact that when we camera in the room, even if we cannot visually see somebody, even though our cameras are great, there might be someone standing just outside the room. So we always make sure to be aware of our audience and to know that, are we speaking to the healthcare proxy if the patient's intubated? We always want to make sure we're identifying the patient through two identifiers, and we always want to make sure that we're identifying who could be listening in. So that's a great point, Craig.
Thank you both for clarifying and going over that, because it's these small details that are actually big details and can make a huge difference for someone's experience. Let's see. Okay, Craig, did you want to elaborate on what you just put into the chat?
Well, let's see if there's other, what other questions there are, what other thoughts there are around this, and then I can touch base on it very quickly.
Any other questions from participants? All right, Craig, if you wanna talk a bit about this.
So this goes, Bob, to your question of costs, and as we look at virtual health, I love all the ideas of creating access and making things easier, but you really bring up a good point, which is who pays for it. And if you are a resource limited area, define that as you will, if you don't have the capital to invest in an infrastructure, what do you do? And the finance folks will always ask kind of what's your ROI, and one of the things I think has to be established very early on, and something that trying to do a little bit better job of is really understanding, are you looking to kind of capture value, so lower your costs, either supplementing bedside teams with virtual teams, creating a hybrid care model in that sense, or are you trying to capture, and so are you trying to capture that value, or are you trying to create value? And this is where I think programs such as the safety rounds really tries to create value. We're not saving costs. We're not reducing bedside team numbers. We're supplementing them in some ways, but you still need operators at bedside. You still need that human touch. It's not to say it's being replaced. It's really to say is, if we can give a nurse, a physician, an ACP time back in their day, there is value to that. There is an inherent value to that person. If a nurse can, be in one room doing something and we can virtually do a timeout with someone else, it saves that nurse. The same with guiding an ACP at bedside through a procedure, it saves a proceduralist from having to come away from what they're doing. Rapid response programs where you can have a virtualist there, start that process. The rapid response team doesn't have to stop the family conversation they're having to run away and then hopefully come back in some amount of time. And I think really, if there are people here thinking about adding virtual in and creating hybrid care models, really sitting down and thinking, are you trying to create value, or are you trying to capture value, and differentiate between the two of those? And that may help those next decisions into understanding, is the upfront cost worth it long term? And I'll kind of stop there.
Agreed, Bob. Yes, those are great points, and definitely something, to consider if you're venturing into a hybrid or virtual care model. Any other questions or comments from participants? Heather, Craig, was there anything else you wanted to share or speak on?
Oh, we could talk for hours. Don't get us started. We love virtual health, so we'll just gab on and on and on. But
Well, thank you both. This was a great presentation, and again, this will be shared with our telehealth partners far and wide across the state. Will be archived on our AHI YouTube page as well. So this will reach more partners. And thank you for your time today. We appreciate that. I just have a few updates to share. No updates from Fort Drum Regional Health Planning Organization, but I will share as a reminder to participants that the 2024 North Country Leadership Summit is taking place October 9th and 10th at the Lake Placid Conference Center. Registration is open, and the agenda is up on the registration page. I'm just going to pop that link right into the chat, and this will go out with the meeting notes as well. So if you have not already registered, please do so. We have a great two-day lineup of presenters, keynotes, and panels. And also included in the agenda and with the meeting notes, some additional information, the 2024 HRSA National Telehealth Conference report, some other reports that we've included in upcoming events. Will remind you, in addition to some virtual webinars, the 2024 10th Annual Northeast Regional Telehealth Conference is also taking place today, tomorrow, and the following day in New Hampshire. So if any of you are attending that, looking forward to hearing more about it. And our next Learning Collaborative is going to take place on Monday, November 18th at 2 p.m. Eastern Time. And I will be sending out the information regarding our speaker and abstract for the presentation focus. Are there any questions, last minute comments, questions from participants?
just wanted to say thank you so much for having us, Andrew. We really appreciate you taking the time and allowing us to come speak to everyone here. Thank you so much.
Yes, thank you, Heather, and thank you, Craig, for your time. We appreciate it. Oh, no, Wendy, sorry, and I don't know if some of you hopped on late and didn't catch this. We don't have any updates from state or CMS. So I reached out to DOH, OMAs, and OASAS, and no updates from those three state sectors. Thank you for asking. Well, I'll give everyone a few minutes back in their day. Thank you for joining today, and we'll be sharing the notes and the recording soon. Have a great afternoon, everyone. Thank you.
Thank you.